Good morning, everyone. Today I'll be presenting my lecture on the topic Atraumatic Restorative Treatment. Starting with the contents, these are the various contents that I'll be covering today. Introduction: in many countries, the caries process frequently progresses beyond the reversible stage, and many people believe that loss of teeth is part of life. The main method of treating dental caries is extraction, but there is a need to develop a new approach for oral care for using economically less developed regions, which was enforced by the World Health Organization. The ART was developed in Tanzania in the mid-1980s as a part of a community-based oral health program. The ART approach is based on minimal intervention and maximal prevention, retaining sound tooth tissue. The World Health Organization actively promotes a traumatic respiratory treatment as a viable approach to meet the need for treatment of dental caries. Atraumatic restorative treatment uses manual excavation of dental caries, which eliminates the need for anesthesia and use of expensive equipment and restores the cavity with glass ionomer, an adhesive material that bonds to the tooth structure and releases fluoride as it stimulates remineralization. Atraumatic restorative treatment is non-invasive, making it highly acceptable to patients. Uh, the history was that it was developed in mid-1980s as a part of a community-based primary oral health program by the University of Dar es Salaam. The results of the pilot study were presented at the scientific meeting of the Tanzanian Dental Association in 1986, and a minimal intervention approach later called ART was officially formed. In 1988, WHO Collaborating Center for Oral Health Services Research at the University of Groningen, the Netherlands, developed a model for primary oral health care for refugees and displaced persons, which included treatment of caries by hand instruments only. In 1991, the community field trial to compare ART with mobile conventional equipment was started in rural Thailand. By 1992, a 6-month evaluation of the Thailand study in 1992, it had become very apparent that the children who had been treated by ART happily participated, whereas those treated with traditional rotary handpiece approach were very reluctant to do so. By 7th April 1994, the official adoption of ART by WHO on World Health Day was announced. In 1996, ART was being used in 25 countries. By 2002, ART was adopted as one of the examples of minimal invasive dentistry by FDI at the annual meeting in Vienna. ART was developed by Dr. Joe Freniken, BDS MSc. He was the International Dentist of the Year in 1999. His decade-long efforts promoting accessible approach of cavity treatment to the Chinese Dutch oral specialist Joe E. Freniken was awarded China's prestigious International Scientific and Technological Cooperation Award. In his own words, it was a low-tech method to prevent and treat cavities and can influence the lives of people in a very pleasant way. That is a very valuable way of creating a caries preventive component. Now coming to the definition, the American Academy of Pediatric Dentistry has defined it as a dental caries treatment procedure involving the removal of soft demineralized tooth tissue using hand instrument alone, followed by restoration of the tooth with an adhesive restorative material, routinely glass ionomer. The three goals of ART are that to preserve the tooth structure, avoid discomfort, and reduce infection. The principles of ART are that remove the carious lesions using hand instruments, restoring the cavity with a restorative material that sticks to the tooth. Currently, ART is performed using glass ionomer as the restorative material. Now, the reasons for using hand instruments rather than electric rotating instruments are as follows. It makes restorative care possible for all population groups. The use of a biological approach which requires minimal cavity preparation that conserves sound tooth tissues causes less trauma to the teeth. The low cost of hand instruments compared to electrically driven dental equipment. The limitation of pain that reduces the need for local anesthesia to a minimum and reduces psychological trauma to patients. Simplified infection control. Hand instruments can easily be cleaned and sterilized after every patient. The reasons for using glass ionomer are that the glass ionomer sticks chemically to both enamel and dentine. The need to cut sound tooth tissue to prepare the cavity is reduced. Fluoride is released from the restoration to prevent and arrest caries. It is rather similar to hard oral tissues and does not inflame the pulp or gingiva. For these reasons, ART provides preventive and curative treatment in one procedure. The indications and contraindications for ART are that it is carried out in small and shallow cavities that are accessible to hand instruments, introducing oral care to very young children not previously exposed to dentistry, and for patients with extreme fear and anxiety. For the homebound elderly and those living in nursing homes, for mentally and or physically handicapped patients, in high risk caries cases as an intermediate treatment to stabilize conditions. It is used in enamel caries and dentinal caries. Now, the contraindications of ART is where there is a presence of swelling, abscess or a fistula from the abscess to the oral cavity near a carious tooth. The pulp of the tooth is exposed. Teeth have been painful for a long time and there may be chronic inflammation of the pulp. There is an obvious carious activity, but the opening is inaccessible to hand instruments. There are clear signs of a cavity, for example, in proximal surface, but the cavity cannot be entered from the proximal nor the occlusal directions. In these cases, it is contraindicated. Now, the instruments and materials used. You have the mouth mirror, which is used to reflect light, indirect view, retract the cheek or the tongue. The help of the explorer to identify the soft carious dentine. A pair of tweezers to carry cotton, wool, rolls, pellets, wedges, and articulating paper. Spoon excavator is used for removing soft carious lesions, small diameter of about 1 millimeter and medium at about 1.5 millimeters. A dental hatchet is used for widening the entrance to the cavity, and the applier carver is used for inserting the mixed GIC into the cavity to remove excessive restorative material. A mixing pad and spatula for mixing the GIC and operating light. The light source can be natural or artificial. Artificial light is more reliable, constant, and can also be focused on a particular spot. In a field setting, a portable light source is recommended. The various other essential materials for ART include cotton wool rolls, which is used to absorb saliva, cotton wool pellets that are used for cleaning cavities. Petroleum jelly is used to keep moisture away from the GIC, prevent sticking of gloves to the GIC, and a plastic strip is used for contouring the proximal surface of the multiple surface restoration. Wedges is used to hold the plastic strips close, and GIC is applied as a powder and liquid. The others are examination gloves, mouth mask, operation bed, headrest, extension stool, methylated alcohol, pressure cooker, instrument forceps, soap and towel, sheet of textile, and sharpening stone. The principal steps involved are isolation. An important aspect for the success of ART is the control of saliva around the tooth being treated. Cotton wool rolls are quite effective at absorbing saliva and can provide short-term protection from moisture and saliva. It is used to remove plaque from the tooth surface with a wet cotton wool pellet and then dry the surface with a dry pellet. Soft caries is removed using the excavator by using circular scooping movements like using a spoon. If the opening of the hole is narrow, widen the entrance of the cavity by placing the blade of the dental hatchet into the cavity, turning the instrument forward and backward like turning a key in a lock. Excavation is easy to do when the tooth is dry, therefore change saturated cotton wools for dry ones. Carious dentine is removed with excavator by making circular scooping movements around the long axis of the instrument. Overhanging enamel must be removed with the blade of the dental hatchet. Place the instrument at the edge of the enamel and fracture off small pieces. In order to improve the chemical bonding of glass ionomer to the tooth structures, the cavity walls must be very clean. It is not effective to do this with wet cotton wool pellets, and therefore a chemical solvent is used. There are two possibilities: a dentine conditioner or a tooth cleaner, specially developed for this purpose, or a liquid supplied with the glass ionomer itself. The dentine conditioner is usually a 10% solution of polyacrylic acid. When we apply 1 drop of the conditioner on a pad or a slab and dip the cotton wool pellet in the drop, and that allows us to clean the entire cavity with adjacent fissures for 10 to 15 seconds. Uh, we have to do this holding the cotton wool pellets with a pair of tweezers, then immediately wash the cavity and fissures at least twice with cotton wool pellets dipped with clean water. The glass ionomer liquid can be used for cleaning the cavity if it contains the same acid as is used for conditioning. Usually the liquid is too strong and needs to be diluted. This is done by placing 1 drop of liquid on a pad or a slab, then moisten a cotton wool pellet by dipping it in water. The material used for restoring cavities and sealing pits and fissures is a glass ionomer. This material must be used correctly for achieving good results. The material is supplied as a powder and liquid that must be mixed together. The powder is a glass containing silicon oxide, aluminium oxide, and calcium chloride. Liquid is either polyacrylic acid or demineralized water. Glass ionomer bonds chemically to enamel and dentin and provides a good cavity seal. One of the most significant characteristics of glass ionomer is the continuous slow release of fluoride from the material after it is set. This helps prevent dental caries developing around the restoration. Glass ionomer is not harmful to the pulp and gingiva. During setting, the material may cause the pulp to feel tender. After 24 hours, when completely set, adverse reactions do not occur anymore. Compared to the established dental restorative materials, glass ionomers have higher surface wear and lower strength.